All right. Hello, everybody. My name is AJ Parnell,
And I am Kelly King.
Hi everyone, I'm Alanna Inniss.
and we are going to be taking you guys through our literature review, which was on different types of value-based health models and single-payer reimbursement systems. So this is kind of a high-level overview of our agenda today. We're going to be starting off with talking about some of the goals and challenges of healthcare in the United States. Then we're going to get into the value-based health models, specifically PHSOs and ACOs. And then we're going to be getting into single-payer reimbursement models and then discussing some of the implications and gaps of literature. So starting off here with goals in healthcare in the U.S. So the triple aim is something that is frequently cited in literature today as really defining what the goals in the U.S. are. And the triple aim is made up of seeking to provide, population health, experience of care, and the costs of care. And really what the overall goal here is getting the most people the greatest amount of access to care with the highest quality of care at the lowest total spending. So that's typically what you're looking at with the triple aim. In terms of population health, within the triple aim, we typically want to emphasize preventative care as opposed to like disease maintenance and be much more proactive than reactive to population health. And then with experience of care, it's really all about improving the overall care quality and reducing the medical errors. And we're going to talk a little bit about medical errors in a moment here. And then in cost of care, I think we all know that the costs of care in the U.S. are pretty high. So that's definitely a big goal in healthcare in the U.S. is just to reduce the overall spending related to the cost of care. So these are the challenges in the United States healthcare today. And the challenges really actually define the goals, and they're kind of synonymous with one another. So starting off with access here. So in 2017, 28 million Americans were completely uninsured. And, given the size of our population, that may not seem like an entirely large number, and it is improving. But what the real problem is here is that regardless of if you're insured or not, half of Americans still do not have the access to the care that they need because of the high costs of treatment. So you can see where access and costs are kind of synonymous with one another as well. And then in terms of quality of care, so this is another challenge in the U.S. right now. Medical errors specifically are the third leading cause of death in the United States. And in a study that happens every couple of years by the Commonwealth Fund, the United States has actually been ranked last, 11th out of the top 11, top industrialized countries in the world from 2004 to 2014. So, in terms of what our potential is compared to, other industrialized countries, we are ranked pretty low. And then spending. Everybody knows the spending problem in the U.S. In 2018, we spent $3.5 trillion on healthcare, which is a big percentage of our GDP. It's an increasing number year after year, and it can make up the GDP of most other countries in the world. So, we wanted to treat our literature review as kind of, using the goals of healthcare to answer what the challenges of healthcare are. And Alanna is going to kind of give a high-level overview of what the solutions are here.
So the solutions, we want to make healthcare better. We want to improve it, which is why we did this literature review and also why we're in this program. So the solutions, the inconsistencies in the current U.S. healthcare delivery model and financial reimbursement structures are often cited at the core of U.S. healthcare challenges. Proposed solutions are frequently recognized as varying models of the value-based care delivery and single-payer reimbursement systems. And Kelly and I are going to talk about that with the population health models and accountable care organizations.
Thanks, Alanna. So the term population health, it was initially defined in 2002 as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And throughout the years, there's been various definitions applied to the term population health, but the centralized goal has always remained the same. and that goal is to provide quality care at a reduced and sustainable cost. So implementing population health really involves a shift in infrastructure, and that's moving from disease management to care management. And education, outreach, health coaches, wellness programs, among others, are the key components in the implementation. Community needs assessments really determine what components are necessitated within the community. And multidisciplinary teams, physicians, allied health professionals, all non-clinical staff, administrators, all key stakeholders play a crucial role in this implementation. Some of the challenges that have come about is measuring outcomes in this model, and it's all related to data collection. There's been a shift in collecting data from one source, such as claims data, to capture financial data or volume data, and that's shifting to collecting it from a variety of sources. And some of it is from the population directly itself, such as social determinants of health. Some of it's straight from the medical records, some of it's still from claims data. And none of this is really standardized between organizations. So the electronic health records are not optimized. So an investment in technology makes it necessary, but also costly. The other challenge is HIPAA restrictions still causing barriers to share data between organizations. And some of these demographic details are really crucial to obtaining accurate data. So now I'm going to turn it over to Alanna to discuss accountable care organizations.
So accountable care organizations, also known as ACOs, are made up of doctors, hospitals, and other healthcare providers. One of the goals of ACOs is to increase preventative care, coordinate through all levels of specialties, and all areas of treatment. When in care, patients are used under the managed care model, and they are dominated by insurance companies. So what ACOs go and do is that they help them, patients and doctors and specialists, provide the best quality of care that they possibly can. When ACOs succeed in doing so, delivery and healthcare spending funds efficiently, the organization shares its savings with Medicare programs. ACOs also focus on patient-centered models and help teams develop an individual plan according to the patient's needs in different settings, such as primary care, hospitals, short-term facilities, long-term facilities, and specialists. Accountable care organizations also go along with population health. The connection between population health management models and ACOs now attribute to overall healthcare of the community and all ACOs to keep patients healthy. So population health management plays an important role in this, especially with the Affordable Care Act that was recently in 2012. So in order to improve these in communities, they need to determine which geographic locations for communities where patients reside in to overlap ACOs and community population health. They need to decide what the level of overlap is in geographic areas, collaborate with markets, and find out what patients' needs are in their different areas. They also use global payment fees to support public health and activities as well. And I'll hand it over to AJ to talk about single-payer reimbursement systems.
Thanks, Alanna. So, single-payer reimbursement systems are a pretty hot topic in world literature today, specifically in the United States right now because of all of the mentions around Medicare for All. So Medicare for All is kind of a concept that's really been made popular through politics. Everybody knows that it's part of Bernie Sanders' campaign platform. So it's kind of been the national introduction to the United States, which is why we see it so much in the literature today. Specifically with Medicare for All, we see a lot of proposals for, at a federal level and at a state level. Nothing has gone through quite yet, so it'd be interesting to see, based off what the literature discusses, what single payer would actually look like in the U.S. But the term single payer itself in the literature is really universally identified as a heterogeneous term, really meaning that it just has several different approaches. So there isn't really one way or another to just define what a single payer reimbursement system is, or what a single payer concept is. There's a lot of similarities and a lot of differences within the different approaches. But overall, it's viewed generally as a healthcare financing model where reimbursement for healthcare services is issued or collected by a single entity that's usually affiliated with government. So with single payer, you also see a lot of similar terms that'll pop up in different articles and studies. One of those terms is universal health coverage, and this can be described this can be used to describe certain types of single payer models. But what universal health coverage is it's really a reimbursement coverage system for the entirety of any given or for the entirety of a given population without any kind of eligibility requirements. So we see that in Canada, we see that in the UK, a system where the whole population will be covered under will be covered under some kind of reimbursement system. And then you have socialized medicine, which is another frequent topic that you see in the literature about single payer systems. And this is used to describe a system where all aspects of healthcare are owned, operated, managed, and just generally facilitated by government. And this could be used as something to describe a single payer model as well as a universal coverage system. And we see this in Spain and Cuba. And we actually see comparisons of this to the current VA system, since the entirety of the VA is funded and operated and through government. All the VA and all the hospital employees are government staff. So the VA is considered to some a socialized medicine model. So looking at some of the main literature that really focuses on describing the different types of single payer reimbursement systems. So you have Gleed, Black, Lauerman, and Snowden, and then you have Fox and Poirier. Both of these are similar because again they reinforce the variation of the term single payer, and they reinforce the fact that there can be different approaches to it. So with Gleed specifically, this is a Commonwealth Fund study where they compared, the top industrialized countries who identify as having a single payer reimbursement system. So looking at Canada, the Netherlands, Australia, the UK, Switzerland, some other countries, and they're comparing the different facets of it to basically try to take away a lesson learned to be able to apply to the U.S. with the discussion surrounding a potential single payer system here in the U.S., right? So they identified some commonalities and some variations in how certain things are approached, like, cost sharing. Some countries have cost sharing. Most countries do have cost sharing. But, how cost sharing is managed can vary from country to country. Some can have cost sharing on all services. Some can have cost sharing on just pharmaceuticals. And then national and local government funding is another one where, we see similarities in countries, but it varies from country to country how it's managed. Spain, for example, is a nationally funded single payer system. But then if you look at Canada, Canada is managed at the province level. And each of the provinces of Canada have to meet certain requirements to receive funding at a federal level. And then at the local level, there's further funding from there as well through taxation and premiums and cost sharing. And then one of the really interesting thing was the role of private payers. Because typically when you think of a single payer reimbursement system, you don't think of private payers since you think of one payer. But the takeaway here is that private payers, exist in most single payer systems, and they play a generally active role in many of them. Canada, for example, Canada is again, it's looked at as kind of the pinnacle model of what a single payer system could look like. But in Canada, 30% of all healthcare insurance claims are actually financed through private payers. So private payers typically play a role of covering the non-covered services of the single payer coverage. So, really the overall takeaways from this study were that, in a single payer model, looking at the single payer models of today, cost sharing is still highly likely to exist, and private payers, are still highly likely to exist and play active roles, if applied to the U.S. system today. And then looking at Fox and Poirier, so this is, like I said, they reinforce the variation of the approach of single payer. But instead of categorizing and comparing at a country level, they kind of categorize into broader labels. So one of them, you have a National Health Service, which is a model that's fully financed by government with no eligibility requirements. So you kind of see an overlap with universal health coverage with that term, right? So an example for that would be, proposals for Medicare for All, where, everybody is covered, the government's going to pay for it, regardless of who you are, what you do, things like that. And then you have a national health insurance model, where benefits and eligibility are determined by the government, financed by the government through taxation, as well as cost sharing and premiums. And then, Medicare today, or the VA, again, would be examples of this because, not everybody is eligible for Medicare, not anybody is eligible for VA benefits, but it's ultimately funded through the government. And then you have social health insurance, which is a model a little bit more complex, that you see in Germany, where you have multiple non-profit private payers in a country with an insured citizen requirement. So this is somewhat similar to the current payer system today, where we have multiple private payers, and insurance is for the most part offered through employers, absent the whole regulation of an insured citizen requirement. So yeah, that's how Fox and Poirier categorize it at a broader level, and then we see comparisons at country levels as well. So looking at some of the implications and literature gaps for both single payer and value-based strategies. So one of the biggest implications of single payer is that there's just really no clarity as to what the cost implications are for the U.S. specifically, because of the variation of the approach. There's not one way to do it. There's not one way that's been proven to work better than other ways fully. And the other part of that is the gap involved with the literature. It doesn't address the actual economic structures of these countries. So, it's difficult to compare free market countries to high tax, socialized economic countries, and their and the potential integration or translation of their healthcare systems. So there's just a general lack of clarity on what the actual real granular cost implications would be in a short-term and in a long-term basis. And then the other big thing with single payer studies is that they don't ever really actually address care delivery. And I think we've seen here that care delivery can be something that not only addresses population health and the results and quality of health, but it could also address financing. And we see that in the literature and kind of creating medical teams around illnesses and how that can reduce unnecessary utilization and spending. Well, single payer studies, have focused solely on the financing and not enough on the delivery. And then with value-based care, what we see here is a general requirement for widespread provider buy-in. We don't really see any functionality occurring unless, the majority of people get on board here. And then, as Kelly mentioned earlier, an investment in technology and understanding the data and kind of overhauling our current EMR and EHR systems if we're going to meet our intended impact. So thank you all very much. Again, my name is AJ.
And I am Kelly.
And I'm Alanna.
And we hope you enjoyed our presentation. Thank you.
Thank you.